we have a site in Vancouver, and Cicero as well. And we work very closely. We're under the same roof as medical, so we work very closely with pediatricians, and we have some really good practices in terms of interdisciplinary work to help improve health outcomes. So happy to be with you guys today. Also, if it is a smaller group, I really don't mind having this more like a conversation. And so I know this is for the whole state, but I know sometimes the folks in Chicago have different issues than the folks downstate. So if you guys wanted to put in the chat where you're from, or I don't know if you can unmute yourselves, if you have any questions as we go on, feel free to go ahead. So the learning objectives today is to talk about early childhood oral health as part of child's overall health and development. Oftentimes as pediatricians, they come to you before they come to the dentist. So you guys have a very important role to play. And then going down to risk factors and then social determinants of health, particularly because the high risk patients are facing a lot of challenges to access to care. And we're going to give a couple of examples, not necessarily cultural beliefs, but just more about social determinants of health and how there are ways that we can support the patient more. And then we're going to talk a little bit about the oral health landscape in Illinois. And that's where I really would like to get your feedback to see what you guys are seeing in your communities and your patient population. Next slide. Yeah, so this is from HHS in 2020. There are profound and consequential disparities in the oral health of our citizens. This is a burden of disease that restricts activities in schoolwork and home and also diminishes the quality of life. There were some really interesting studies about missed school hours due to dental pain and missed work hours due to dental pain. And it's something that hopefully we can all work towards solving. Next slide. So early childhood oral health is going to be like the first topic that we get to, so we can keep moving. This is the eruption pattern. So for those of you that don't know, these are just what times you're supposed to get your teeth and what time you're supposed to lose your teeth. This is for typical eruption patterns. Of course, there's going to be a lot of variations of that, but this is quote unquote what's typical. So as you can see on there, kids start getting their front teeth at around 8 to 12 months at the top, and the bottom ones typically come in first. They start as early as 6 months. With that being said, it's normal to start seeing it at 4 months or so. And I can know my own kids, they didn't actually get teeth till after they were 1. So, and you can see it kind of starts in the front and then you get a couple in the back and then it moves forward. And you can also see something that comes up a lot is parents sometimes say, well, they're going to fall out anyway. So why do we have to fix, the baby teeth? And you can see that some of these teeth are not supposed to come out until 12, sometimes even 13 years of age. And if that tooth is infected or if it has a cavity, that's a long time to be living with an abscess or pain, especially when that tooth came in. You can tell the second molars, they come in when the child is around 2. So that's 10 years that tooth hanging out in the mouth causing the patient pain. So it is important to address issues on baby teeth. I know you guys understand that, but sometimes the parents need a little bit of a reminder. Having teeth is important. It helps them with speech development and it helps maintain space for their adult teeth to come in. And so having had cavities in the past is the strongest indicator of future cavities. So if you had noticed something in the past, they went somewhere and got it treated, at that point, it's a good idea to recommend that they have a dental home where they're going in every 6 months so we can catch things early on. And then obviously if they do have an abscess, infections in kids can go from 0 to 60 quite quickly. And so it's really important to be able to catch that before it turns into sepsis. Next slide. So actually everyone says asthma is the most chronic disease of early childhood. It's actually early childhood caries, or otherwise cavities. Up to half the kindergartners and 2/3 of late adolescents have cavities. It can cause pain, right? They have difficulty eating or they stay away from certain foods because it's challenging for them to eat it. If they're having significant pain or abscesses, they're going to have a hard time sleeping. Also, their need for dental procedures are obviously longer, more painful, the more work they need to get done. And there was another study that showed, I don't know if it's cited in this, that they lose days of school. They have difficulty paying attention. And there's the study, 51 million school hours are missed due to dental caries, which is quite a lot. Next slide. So these are some charts. This is not necessarily, we have some graphs specific to Illinois. This is more looking at it across, this is from the NHANES study. And this basically shows you, based on age group, how many dental cavities they have. And then the second part is how many untreated dental cavities they had. And you can tell that there's some actually pretty high numbers in there, particularly in the 6 to 11-year-old age group. What we would like to see is we would like to see those 6-year-olds come in before they're 6, right? So that we could take care of them while the cavities are small, or maybe they could get some preventive intervention to stop them from having untreated cavities when they're older. Next slide. We kind of touched on this, but yeah, I hear this so much, like, oh, they're gonna fall out anyways. And it's like, no, like let's go back. Like you want to treat these because they can go again, it can cause pain, it can cause major problems for the child that's pretty preventable for the most part. And also, like I had mentioned earlier, previous caries is the strongest indicator of problems when they're older. So treating those cavities when they're younger will impact their oral health for their adult life too. And so it also causes, for a Medicaid and from just a cost and time perspective, it saves money. So the earlier the child is when they come in and establish a dental home, that is not an episodic care, but that they establish a dental home, the less time and money they have to spend on dental treatment when they're older. And general anesthesia dental visits are not easy. They're not fun for the patient because a lot of those patients are too young to sit through a typical dental procedure. And obviously there's risks and side effects with general anesthesia. So if we can prevent that, we obviously should. So next slide. So I like this slide a lot because we can take this to policymakers and show this is why we need to make sure we're covering more Medicaid services or insurance or dental insurance services for kids. So the age of their first visit, you can see their average dental cost for their lifespan each year is only $262. If they don't go and see a dentist till they're 5, every year their average dental cost is going to be $546. It's actually quite a big gap. And it's also not just financially for the policymakers more efficient, it's also better for the patient because then they don't have to come in and get as many procedures done. It's just a better experience overall for the patient the earlier they can come in. Next slide. The age of the first preventive dental visit has a very significant positive impact on dentally related expenditures, with the average dental cost being less for children who received earlier preventive care. Right. So now we're going to talk about we're talking about getting people to the dentist when they're younger, but now we're going to talk about like what are some barriers they're facing and what are some ways we can support that a little bit more. And we're going to talk about some of the local issues in Illinois that our patients may face. Okay, so the graphic can be a little bit confusing, but I first want to highlight the Venn diagram at the bottom. These are the things, so the cavities kind of form in that sweet spot in the middle of all 3 circles. And so you have to have the substrate, which is the sugar in the diet. You have to have the microflora, which is the bacteria, and then you have to have the host, right? The bacteria are eating away at the teeth. You have to have teeth in your mouth, right, to get cavities. And so what we would like to do is move people out of that little sweet spot in the middle and so that they don't get cavities, right? And there's multiple ways to do that. You can alter the diet. You can brush your teeth and have better hygiene to prevent the microforma and the biofilm from forming. Can't do anything. Everybody's going to have teeth, hopefully have teeth eventually. So that's always going to be there. When you look at it from a more global perspective, which is why I like that top image, and it talks about like, there's obviously a genetic component to it, talking about health behaviors and practices. Studies have shown if they have dental insurance and they utilize that dental insurance, they're going to have better outcomes. Then there's family level influences, like who's watching the child. If they're going, oftentimes the mom will bring them in and be like, well, I work and they're at grandma's all day and they don't brush their teeth. Or sometimes there's challenges, or if they're at daycare, they're eating sugary snacks sometimes if they're whoever their caretaker is and they're not always brushing afterwards. Then we get to community level influences, and that's where the social determinants of health come in. Like Food deserts are real. Sometimes they don't have access to nutritious food, so it's hard to ask them to eat nutritious food if we don't have the supports in place. There's also just physical environment, and there's also access to care. If there's no dental, let's say you have Medicaid and there is no dental office near you that accepts Medicaid, how are you going to get to that? If you have an insurance, but nobody near you is in network, including private insurance plans, it's going to be kind of hard for you to go in and get it done. So, or get your preventive visits in. So there's a lot of factors to this, basically, is the overall gist of this slide. But if we can understand them a little bit better, we can help address that with the families. So we talked about this. So things that we can help with, right, is education, access, and quality. And then we can provide our own like oral health or health prevention education to the parents and the caregivers when they come in, as well as to the children. And then healthcare access and quality. I work for an FQHC, so it's a little bit easier for me to say, but we're very, very systematic in making sure our clinics are located in communities that need us the most. And then the economic stability and neighborhood and built environments and the social and community context, these are all important for us to understand. But I think it's a little bit outside of our scope as like healthcare providers to come up with a solution for those, but we can work with community partners to address them. Next slide. So kind of like we said, 80% of what affects health outcomes is outside of the traditional boundaries of healthcare delivery. So we can fix the 20%. That's within our scope and that's within our abilities to fix. But I do think it's important for us to work with community partners and with our patients to better understand the other 80% and see if there's ways that we can fix that, including physical environment, social factors, health behaviors, and hopefully improve health outcomes. I love this slide so much. So when I first started, I remember I got my MPH about 13 years ago. And when I was there, only the first 3 slides existed, and it was a diagram that we used often. So the reality is like the shortest person can't see the game. And equality is giving them all the same size box. Equity is giving them different size boxes so that everyone can enjoy the game. And that's where the diagram ended. And now I love it. They added another kind of panel to this where it's justice, where we don't even need a fence at all. And there are ways, even as healthcare providers, that we can kind of help tear down that fence so that everyone can enjoy the game and everyone, I guess the analogy for this is enjoy access to healthcare. Next slide. So I don't know if you guys have seen this health impact pyramid before, but it's used to explain, or it can be used to help with a lot of health issues. But examples in oral health are, you start with the bottom of the base, which is socioeconomic factors, and then we want to change the context to help make their decision, help with our decision making. We want to work on long-lasting interventions, clinical interventions, and then counseling and education. And then the higher you go, the more of an individual level you get to, right? So the bottom is these large scale policy community impact, and then you slowly work your way up to the patient. So socioeconomic factors is getting them dental insurance, securing employment, that type of thing, getting their community safe, getting them grocery stores. Then you go up to community fluoridation. Community fluoridation has shown great impact in decreasing childhood caries. Enforcement of dental exam requirements. I love that in Illinois, their school forms, they have to go see a dentist at least, I think it's 4 times throughout their K through 12 educational experience and get it signed off on. So at least we know that they're going to see a dentist if they're in Illinois and if they're in a public school. Protective interventions would be your sealants, your fluoride, your preventive care, and then your clinical interventions are, hopefully it doesn't get there, but if they need, evidence-based care, actually intervention, we can do that. And then counseling and education for maintenance. Next slide. So this is where I'm kind of curious to hear from you guys. Social determinants of health are can be very hyper local. So this is where what we see in Chicago, this is what we see, and we do needs-based assessments with our patients, but oftentimes like things like food insecurity, not having healthy grocery stores, not having places to get, fruits and veggies and such, a lot of processed food, and then access to care. Is there a clinic near you? Is there a place you can go that takes your insurance? Do you have transportation to get to where you need to go? Is there a shortage of providers in the community? Even in Chicago, although it's very saturated, there are health professional shortage areas where you'll find that a lot of healthcare providers are congregating in certain communities, and some communities don't have any. Lack of preventive visits, which I think is tied to the access to care issue, and the inability to get time off during clinic hours. So what does that look like? Are there ways you can change that in your clinic? I know some nights we do evening hours. We have Saturdays open to provide more access to care for folks who work a traditional business hours job during the week. And then there's social and economic factors as well. You guys can put in the chat. I'm curious again. I know, like, for example, I've talked to some folks in central and southern Illinois where transportation's a bigger issue, where people may not have reliable cars, but the nearest provider is sometimes 60, 70 miles away. And so I'm curious to hear what some of the challenges are that you think your patients are facing. So feel free to drop that in the chat. And next slide. So now we're going to talk a little bit specifically about what we've seen in Illinois. And we have a really great state dental director who's put together with IDPH some great data points that are helping guide our policy forward. Next slide. So IDPH came up with Oral Health Plan 4. So they do an oral health plan for the state every year. The last oral health plan was from 2021 to 25. They did a lot of listening sessions. They talked to people who they went around the state. They did a great job. And the long history of public health planning has led to incremental improvements in oral health and the oral health status of Illinois. However, the oral health status is less than ideal for many. Preventable diseases are really prevalent among a high-risk population, and there's an unequal burden of disease among certain populations. And so we want to really target that high-risk population group. Next slide. So this is just to show you like how Illinois has been working with some of the national data that's out there. So any box in purple is what the Illinois Oral Health Initiative is. Anything in green is the National Oral Health Initiative, and then anything in blue is the Illinois Oral Health Plan information. So you could tell that they had their first oral health plan in 2002, pretty much in result to the U.S. Surgeon General had a report in 2000 about oral health in America. And then Illinois kind of responded to that a couple of years later. And you can see they've always been responsive and working closely with our federal guidelines and federal data that we've been getting. And the fourth oral health plan was initiated in 2019. And so they've also released, which we're going to get to, 20 years of data of oral health and weight obesity status of Illinois third grade children, which I thought was really interesting. Next slide. Okay. Sorry, I saw a question and I'm gonna just get to that question right now. Thank you, Julie O'Keefe. My patients who are developmentally delayed, autistic Medicaid patients cannot get care even at Lurie's and UIC, but would appreciate any referrals. Yeah, so in our clinic on Wednesday mornings, we actually have an IDD clinic specifically for dental. I'm happy to work with you. And UIC's College of Dentistry just opened a special needs clinic as well. So they have more availability now than they did in the past. And we are more than happy to see them. I know it is very challenging for IDD patients. If they need general anesthesia, our only options are Illinois Masonic and UIC. So hopefully, Julie, you're located in Chicago, but it's not unheard of, unfortunately, for people to have to drive in from hours away for our IDD clinic days. I think we see patients as far as Bloomington Normal, which is like maybe 3-hour drive from our clinic. So happy to give you my email address. If our clinic locations are convenient for you, you can come to us, you can send your patients to us, or I have to look up how to get to some of the other resources for you, but I can do that for you if we don't work out. So yeah, part of the American Dental Association did a study on why do people not go to the dentist? What's the reason why? And so you could tell that the biggest one by a long shot was cost. Even if people do have Medicaid, even it doesn't cover everything. So cost, inconvenient location and time, and then afraid of the dentist. So those are things that we can kind of help address in our practices. Being afraid of the dentist, I think the easiest way to fix that is if the child comes in for consistent preventive visits. Like comes in consistently for well child checks. If every time they're coming to see me, it's because they have an abscess and we need to take out a tooth, by the time they're 12 or 13, they're not going to want to go see the dentist because they only can equate going to the dentist with like fear and pain and difficult procedures. So my favorite appointment is the first appointment for all babies and just getting them in and getting them used to it, letting them touch all the stuff and see how it goes, see how it works, and having like a really positive first, second, third experience. So if they do need care down the line, they know, oh, like this is just the one time, like we've had all these other really great experiences. Next slide. Illinois pediatric oral health data. So this is how Illinois is faring compared to the rest of the states. Um, percent safe by community waters that have fluoridation. Illinois is doing fantastic with that. Compared to the national measure. I will say, we always do ask our patients what their water source is. If they are living in a mobile home, most communities in Illinois have community water fluoridation. When I was looking at it a couple years ago, the only communities that didn't is sometimes there's these mobile home communities that are kind of off the grid with their water system. They use their own well system, and they're usually in an unincorporated area. They're not connected to like a city's water supply. Those are the only ones that don't have fluoridation. So we always ask the patient, like, oh, like, where are you living? Like, what, where do you get your water from? Tap water is great. Tap water has fluoride in it. So, we try to have people drink with tap water, brush with tap water. You can tell that I think it's very much because of our community fluoridation system that our third graders get less cavities compared to the national average. However, you will find that we have a higher percentage of untreated tooth decay among third grade students. So the ones that are getting cavities are having a hard time finding a place to get them fixed, or they're not going anywhere to get it fixed. Dental sealants, which is a preventive measure, is better than the national measure. I think it's great. So many schools in Illinois have the dentist just come to the schools and do all the preventive care. I think that's wonderful, but that does not replace the need for a dental home, because if they do have a problem, they're not doing it on these dental vans or these school dental visits. And so there seems to be, if you look at this data, a gap between preventive visits and then actually going and getting the care. Next slide. So this is specific to Medicaid, and this is IDPH data, again, under the age of 21 who got a dental service between 2010 and 2019. The numbers were actually kind of trending down from 2010 to 2019, and I'm going to be very, very curious to see what the numbers look like after COVID. As you know, during COVID, like a lot of dental offices closed down, a lot of those school dental programs shut down, and so I'm very curious to see how those numbers change. Sealants went down, any dental service went down, preventive dental services went down, but oral health service by a non-dentist went up. And I think that's amazing. And I think that's where pediatricians can really, again, play a role in them, because you and your staff are typically who they see first before they go to the dentist. And there's interventions that you can do in your office that help. Next slide. So this is also specific to Illinois about racial and ethnic like oral health inequities and disparities that we're seeing. And you can tell the light blue is non-Hispanic white, there's non-Hispanic other, which is yellow, Hispanic Latino is green, and non-Hispanic Asian is red, and non-Hispanic Black is the dark blue. And unfortunately, oral health inequities disproportionately burden the Black and Brown communities in Illinois. And there's a lot of, like we talked about, some of the social determinants of health that have something to do with that, or ways that we can try to help mitigate. But there definitely is a health inequity that that hopefully we can get to the bottom of. Next slide. And this kind of touches on it again, and you could tell oral health service provided by a non-dentist. So that's typically pediatricians for children, right? Because you're the main medical health service line that they're seeing. And it was slowly going up. It went really high, and I don't know why it went so high in 2017, but that's really great to see. So hopefully we can get those numbers to trend back up. We were talking about health professional shortage areas. There are 78 of them. They're called HIPSAs in Illinois, and 76 of them are based on a shortage of dentists that serve low-income Medicaid patients. And again, curious to see where you guys are all from, but you can tell like the middle of the state, the central and southern part of the state have challenges, but you can also see there's pockets in the middle of Chicago that have challenges as well. It's done as a proportion of how many patients are living in the area that have Medicaid based on the number of providers in that area that accept Medicaid. And that's altogether population-wise, 2.3 million people in Illinois live in dental HIPSAs. It's a lot of people that have access to care challenges. Next slide. So what happens when they don't go to the dentist? Well, they get abscesses and pain and end up in the ED. The ED is not the best place for them. I mean, it provides acute care, but it's not the best place for them because for the most part, EDs don't have dental departments in them. So the most they're giving them is antibiotics and pain medication and saying, go find a dentist. We don't take teeth out here. We don't do oral surgery here. I know there's one FQHC that has a clinic embedded in a couple dental chairs embedded in a hospital, which is really great. I'm not familiar with very many of them in Illinois, but there are hopefully ways that we can work together. We have a pilot project going on in Rockford right now where patients from the ED that are coming in for dental services are getting a fast track referral to our clinic so that we can provide definitive care for them. So they're not like constantly going to the ED for dental issues. Perfect. So I'm really happy in Algonquin, Illinois, they have state insurance, can find a provider when they call the insurance company, and you refer at age 1, and that's really wonderful. So thank you for referring them. You can refer them even as babies. I think a lot of our first dental visits, even before one, are just educating mom, dad, caregiver on oral health preventive, like how to brush your teeth at home. Please don't put juice or soda in the bottle, things like that. Next slide. So since you guys are all pediatricians, what are some things that you guys can do to help mitigate these health inequities? Most children don't see a dentist until they have problems. Some of that is parent education. Some of that is also they just can't find a place to go. So about 40% of early childhood care starts before age 4, and a lot of children don't have access to dental care, and then COVID-19 has made that more challenging. So we're going to get to some of the things you guys can do in your office. Next, I don't know if we go into that a little bit more, but if we can get to the next slide or not, we can, oh, we're at the questions part, so maybe not. So some things that pediatricians can do in their office is offer preventive services. You guys can do fluoride varnish, which is super affordable. I think it's like $1 per unit dose. Your medical assistant can do it. There's a Bright Smiles training program that's done through ICAP, and I think IDPH had some slides in there too. We are doing our part by trying to get residents to do the training so that when they graduate, you know, and go off into their own practices, they have a little bit of that background about it. There's ways that you can screen at your office, questions you can ask about diet, nutrition, all those things are really, really helpful. And then secondly, something that I've been trying to work on, because it just makes me so sad when I hear that people are driving 3-4 hours just to come to our practice, is trying to connect pediatricians in the area with dentists in the area that are comfortable seeing younger children. And I know not all dentists are. That's something we're working on the dental side of things, but finding ways to build those relationships so that you can just get a sheet of, these are dental places that you can go to that do take your insurance. You can call, or maybe just accept Medicaid in general. Here's your list. Here you go. As Joanna mentioned, they can also call their insurance to get that list, but sometimes if you know they're overburdened with a lot of other issues, it's easier if you just give them a list of places they can go to and they can call and make that appointment. I also think it's really helpful if you build that relationship with 1 or 2 people that can treat the urgent cases. So let's say by the time they see you, they already have an abscess, they already need the tooth out. You guys can give them the antibiotics, you guys can help take care of them, and then be like, hey, you need to go, or maybe even have a medical assistant or your front desk staff be like, do the warm handoff where you're calling and helping make an appointment to make sure that they actually get in. I have found that some of my patients need a little bit of assistance navigating the system. And so sometimes the benefit of a warm handoff, especially for those really urgent cases, can be super, super helpful for the family. And then they have a greater chance of actually showing up to the other appointment. They know where to go, and they have all the information before they leave their pediatrician's office. Happy to get some more in the chat about where other people are from and what some of the other challenges are that they're facing. And Julie, did you get, I put my email in there for, but you didn't mention, Julie, if you could just type in the chat, with your challenges with the IDD patients and your autistic patients, where are you geographically located? We can wait for that to come through. Do you guys have any other questions for me? Again, I was thinking this could be more of a conversation. So feel free to type anything in. Chicagoland area, perfect, western suburbs. Okay. Yeah, if the patients, I mean, western suburbs is still a little bit far. Our IDD clinic is on the far south side of Chicago. But if they have a way to get to us, we would be more than happy to see them. So we have a couple, myself and another dentist have certificates in treating patients with dental disabilities. We got further training in it. So we would be more than happy to try to see those patients if possible. And then for somebody else at Chicagoland area, how are you sending your patients to the dentist? What are you guys doing? I think it was Hannah. FQHCs are a really wonderful resource. Yeah, that's a tough one. Toddlers that are still nursing during the night. That is definitely a challenge. I know a lot of babies are either on the bottle or being breastfed longer than what is recommended. I advise them, take a wet washcloth and at least with your fingers, take that wet washcloth and wipe off the teeth. Um, I know a lot of babies that go to bed still, even after age 1 with a bottle. And you see that I actually had two, it just was really hard yesterday. I had 2 3-year-old twins that are unfortunately going to need their front teeth taken out because they were still going to bed with the bottle up until probably 2.5 years of age. So it would be really great to try to wean off of that eventually. But then if you are still doing it, bottle is easier, absolutely. Take a wet washcloth and wipe those teeth when you're done. Just keep it next to you while nursing or whatever, wet paper towel so you can make the clean it off. I actually had another request for pediatricians on this call. Something that I've noticed too is so when the child is going to go get GA, and if you've had any patients that have needed GA for dental care, they usually need a dental clearance from the pediatrician. If you get that request at that time, please send all the siblings of that child to the dentist to establish a dental home. It is far too common for the oldest sibling, when they turn 4 or 5, they need GA for all this dental work. And then you see the same thing happen. And then I see the younger sibling a couple years later, and it's like, oh, they're already at that. And I'm like, oh, if I had just seen that younger sibling when they were 2 and the older one was 4, we would have been able to prevent that younger one from needing GA. Unfortunately, it does tend to run through families. There was another case where 3 of the kids all needed general anesthesia once they hit like around 4 or 5. And unfortunately, we saw the younger kids after, the older kid. And then when I sent the mom was like, oh yeah, we sent our older kid like a couple years ago. And I was like, oh, I wish I had seen the younger children sooner. So if you're sending someone to, or if you're filling out that clearance form, or if you're noticing significant caries in a young child, even if those younger siblings or even younger than one, just send them in. We'll do some nutritional counseling. We'll like chat with the mom. We'll do extra fluoride. There's another medicine out there called SDF that I know there's another training for that you guys may be eventually able to do at your office, and we can chat about that. But there's a lot of preventive measures that we could do on those siblings of children that are going into GA. And that's actually a research study that we're doing to see like the kids that get GA, if we can talk to parents and prevent their siblings from coming in. And you have patients check their insurance first, but you do have a list of local dentists. And that's really the easiest way to do it, is to just give them a list, give them a set of numbers. And hopefully when they get home, they can make some phone calls. We have about 5 or 6 minutes left. Does anybody else have anything else?
And I know a lot of you, I think everyone on the call this morning will be with us in 2 weeks and throughout the next few months on our quality improvement project. So we're excited to have you join us today to get this information and excited to see you over the coming months.
Okay. All right. All right. Well, thanks everyone for your time, and thank you for your appreciation and wanting to learn more about oral health. I put my email in there. You guys can reach out. We can help connect you to dentists in your area if you're having a hard time finding anyone.
Thank you so much for joining us. I will send an email later today that will have the slide deck, a link to the recording if there's anything that you missed, and also a link to a survey. If you fill out the survey, you will be able to get CME credit for attending today. And it also just lets us know what you're interested in, where we can improve so that we can apply that feedback to future sessions. So would appreciate it if you take a few minutes and fill that out. Thanks again. Have a great Friday.